Good morning, everybody. So I think I know everybody here, but I'm Taylor Conrad, so I'm going to be the graduating EMI MCCM fellow. And so for my senior lecture, I obviously had plenty, after 6 years, I have plenty of things that I could probably try to talk about. But I decided that after a lot of soul search and everything, that what I really just wanted to do was kind of go back to more of the basics of the stuff that I enjoy, which is talking about something heavily scientific and trying to distill it in a way about something that I feel passionate about. So we're going to talk about something that I've been researching on and off at various different points with various different people over these past few years, and probably intend to do a lot more research in the coming years. And that's fluids and critical illness. And so I recognize like a lot of this talk might apply a little bit more towards kind of as the patient gets out of the acute phase and towards the resuscitation phase. But one of the things that I'll hope to at least elucidate is we'll talk about some of the history of normal saline, where that came from before, some of the rationales to why I think that it may need to be limited in its use, but also more importantly that like the reality of what we get for intravenous fluids and what we determine for intravenous fluids really has just not been studied properly well or anything like that, and we don't really know. And our current understanding of how the blood interfaces with endothelium and the capillary bed probably is only at the very beginning of the surface being scratched, and we'll actually probably have other types of fluids and therapies coming in now that we're able to study it a little bit more, but there's a lot of limitations that we'll talk about. So to summarize what we're going to talk about, we'll talk about the fluid distribution in body compartments, the 3-compartment model that you're probably all familiar of. We're going to talk about some of the pharmacology and pharmacokinetics of intravenous fluids. We'll talk about the history of saline and some of the components of the different ones. And then we'll spend a little bit of time on the endothelial glycocalyx. And so, you know, for some of my classmates, you'll probably realize that this is my chance to come up here and talk to you about the endothelial glycocalyx, so I'm going to do it. Then we're going to talk about fluid balance and something that I disdain and am interested in at the same time, and management of volume overload. So we'll try to get through most of it pretty quickly, just in case that there's any discussions anybody wants to have in the last few minutes after. So we'll talk about what are the choice of the resuscitation fluids that we have. So obviously we have a whole category, anything that we're going to give intravenously, of resuscitative fluids. We have crystalloids and we have colloids. Colloids, as we typically think of, well, one can be blood type products, which we haven't put in there, but we're thinking about all synthetic things at this point. Albumin, which can come in at 4% along with some saline, or 5% albumin alone, all synthetic, and then non-albumin colloids such as starches and heavy starches, which I'm going to not talk about much here because we know that is bad. So starches associated with renal failure and problems, don't use starches as resuscitative fluid. In the crystalloids, you've probably heard about the difference between a saline fluid, which we typically would consider as normal saline as the resuscitative fluid, and then the balanced electrolyte solutions, which you think of as plasmolite, isolite, normal sol, or Ringer's lactate as something that we use. So just so that we have a foundation as to make sure everybody knows the fluids that we're talking about and kind of how they're categorized. So one of the first things that I want to impart upon is something that you probably already know, but I'm just going to harp upon it, right? Intravenous fluids are drugs. They are medications that we're giving. They have a specific composition. They have specific physiological and pathophysiological effects on the body. The profile is based on how they interact with the body, is based on their composition. So whether it's a colloid versus a crystalloid is a very simple way to think about it. But also their level of chlorine is going to have an effect on the pharmacokinetics as well, and we'll talk about that. Dose-response relationship, so you can underdose someone with fluid, right? You can not give them enough to maintain their hemodynamic and intravascular filling pressure, especially in hemorrhage, or you can overdose them, right? Which is also associated with adverse effects and mortality. It can manifest toxicity, which is associated with mortality, as I mentioned, and there are specific indications and contraindications for fluid, right? So I don't think I've said anything that anybody disagrees with at this point, right? So how do we look at the 3-compartment model? So the reason I want to bring this up is our understanding and knowing, right, from our basic science that when you do infuse a fluid into a person, it doesn't all go to the same place equally, right? We have semi-permeable membranes separating the three theoretical compartments that we delineate the body into. We have our intravascular compartment here on the left, we have our interstitial compartment and our intracellular compartment, which makes up the overwhelming amount of our body volume, right? We have difference in permeability between all of these. The interstitial and the intravascular is protein impermeable, but electrolyte permeable. The intracellular compartment, compared to the interstitial compartment, is both impermeable to proteins and electrolytes, and is maintained by the homeostasis of the cell itself. However, of course, water is permeable throughout all of this, right? We have porins that allow water to shift through these. So the composition of the fluid that you're going to give the patient will distribute differentially into these compartments. But it's also important to understand that loss of things go the same way as well, too, right? So the majority of things that you're going to lose is going to be water, but you will lose a little bit of electrolytes based on the permeability of the interstitial component. And so just recognize, you know, when you're trying to diurese somebody, you're trying to pull fluid off of somebody, you're not necessarily removing only the entire thing that you want to remove, or you might be preferentially removing water, which you may not be doing, right? You've seen some people where you diurese people a lot and they end up getting a lot more hypernatremic based on the free water loss is more excess, right? So there can be a lot of complications to this, and we don't have a perfect answer. But one of the things that I found very fascinating is the actual pharmacokinetics of fluid infusion. And so this is done by some surgeons and some anesthesiologists of the past several decades. And they've looked at things in healthy people. They really haven't looked at things in critically ill or sick people, because that's pretty hard to do, right? So that's kind of one of the basis of the fact that we don't have very good studies on a lot of these things. But they're looking at the kinetics on, we'll take a look at the left side. So let me get my mouse back. The left side is going to represent healthy volunteers. And so these healthy volunteers are then having their plasma volume estimated by looking at the concentration of hemoglobin, which was proven in a prior study prior to before this, to looking at volume composition in the body, and the distribution of what happens when you give a fluid bolus of 1 liter of either a D5W solution, a crystalloid, so in this case it was normal saline, and then a colloid, and in this case it was albumin, 5% albumin. And you look at how much volume was expanded based on the infusion. So as you infuse the fluid, the volume expands. So that's pretty obvious. And as soon as the fluid is stopped, the volume expansion stops and the actual redistribution of all the fluid begins. And so the effect of giving a healthy normal subject 1 liter of crystalloid in about an hour only causes about a volume expansion of about 300 milliliters. So they didn't continue the experiment fully after this in this group, so we only have everything up to an hour. And I don't want to confuse you and make you realize that, oh, albumin stays in the body always. It does not. It also has a rate of degradation and redistribution of the fluid. It's just longer. So instead of about an hour to 2 hours, its redistribution is going to be about 4 to 6 hours. And that has been shown in some other areas. So the albumin that we have will eventually get broken down, especially in varying different disease states, and it will distribute, but the effect of that fluid bolus, the length of time of that fluid bolus is going to be longer. Make sense? And then this is on the right, different disease states, just demonstrating that in different disease states, the effect of your fluid is going to be different. So in a healthy, normal, conscious volunteer, we have fluid administration. This is all of 2 liters of crystalloid given in 60 minutes. And so you see the volume expansion pretty rapid initially, and then it kind of tapers off. And then at the end of the infusion, the volume expansion returns back down. And so if you notice in a healthy volunteer, we never expanded their plasma volume with 2 liters alone more than 400 cc's. In the presence of vasoplegia or vasodilatation from induction of surgery, you get a little bit more of an effect. Immediately after the anesthesia induction right here, as we mentioned, and then in hypovolemic shock, you get a massive effect, right? That patient is intravascularly depleted. You see a large effect of the fluid that's being given. So it's important just to kind of understand that fluid is really only going to be helpful if it's needed, right? If the intravascular, that's kind of one of the ideas behind these pharmacokinetics, is that the intravascular space is optimally filled as much as it can be. more volume is not necessarily going to expand that intravascular space. But if there's a lack of fluid in the intravascular space, volume can have an effect. And then lastly, I want to mention, of course, that these are all non-inflammatory. And so a lot of this goes out the wayside inflammatory, which we'll talk about in a second. So we'll just briefly talk about the history of saline. So let's talk about how much we use. So we use in the US about 200 million liters annually. It represents almost 80 to 85% of all of our fluid use when you talk about intravenous infusion. And this is not necessarily even counting medication administration, which is much harder to count as well too, which can be mixed in various different forms, but is oftentimes mixed in normal saline. Generally, it's considered innocuous by everybody, and it's also considered equivalent and interchangeable. And I hope to change my mind on that. So I'm not expecting you to read all these specific things, but I want to point out a couple things. So this is a list of some of the historical iterations of various different resuscitative fluids that have been used, which really the documentation only goes back to as early as 1832, when Latta created a resuscitative fluid solution during an outbreak of cholera in London at around the time. And that's kind of what got people interested in this concept of fixing it. Interestingly enough, it had nothing to do with expanding volume. All it had to do with changing the color of the blood from dark brown to red, because they felt that that was better. And so by an effect, they were probably replenishing some fluids and electrolytes for people, which helped, but they also killed people in the process. But just keep in mind that the concentrations of this, so they're reported in antiquated units that were used at the time, which is kind of how part of some of the compositions came about, just based on the measurement and weighing devices that they had. So they used drachms, scruples, ounces, and all of these were different amounts of each other in itself. And they were just guessing, to be honest. This was before a lot of the understanding of with analytical chemistry, the understanding the true composition of our plasma volume and solution, but they were just guessing and throwing stuff out. And almost none of them have any representation to either physiological fluid or normal saline at all. These were intravenous. Either intravenous or these were intravenous or rectal. Really? Some were used by fluid, but people have been injecting things into everybody for a very long time. And basically they were proving that you could inject things into people and they wouldn't die instantly, and they might not die. And that was kind of the idea. Ringer's solution came about in 1883, which, just for historical purposes, recognize that it doesn't actually include a bicarbonate. That actually came out a little bit later, which we'll talk about in a second, from Hartman next. So how do we actually get the concept of normal saline? Nobody's 100% sure, but all of this really is kind of based on English-speaking literature from what we can understand. So it is biased in that standpoint. This is really just looking from our Western point of view, but we think that that has been heavily influenced on our current practice. And that the first time that someone described 0.9% saline as a normal physiologic fluid was by HARTOG HAMBURGER in 1888, when he was looking at solutions that would allow a frog's heart to work in a solution for testing, for neurological impulse testing, and for leg testing as well too. And basically he was like, this solution didn't kill it, because some of the other solutions, so it's a little bit hypertonic. But when you have the freezing point depression measurement, which is something that they were able to do at that time, its freezing point depression measurement was as close as possible that he could figure out in human blood. And that's when he did, because your actual measured osmolality and the effective osmolality is different, and that can be measured in difference by the calculated versus the freezing point depression. And so that's where we got it from. And then other people have started to refer to this possible as like a normal solution. How it changed from that understanding to ubiquitous use, nobody really knows. That's kind of where the literature kind of just stops talking about it at all. And it just starts becoming normal and used over the next like 40 years. And then we've only more recently kind of really started to compare these types of fluids. There are a couple things from back in the early time period. And so proctolysis is the rectal infusion, as I mentioned. So before we got into routine regular infusions of fluids, we started giving large volumes rectally because they would be absorbed more that way. And so this was an experimental study of giving different types of random salts to people in the 1910s. So as you can imagine, definitely not something that we would want to be doing, and people died from this. And it was by a surgical group and an OBGYN group. But basically, one of the things that they demonstrated is that too much sodium chloride, as you can imagine, can kill you. And that happened, and they can show that. And so we kind of have known that already from there before. And then Hartmann, which is the kind of basis for the most common balanced salt solution that we have, which is lactated ringers. So he took a ringers-like solution, which was more common at that time, and realized that when he was doing fluid resuscitation for severely ill patients with mastoiditis, pediatric patients, that not all of them were doing well. And he realized that adding a base solution, because of the severe vomiting and dehydration caused just by the systemic illness of the mastoiditis, was causing the more severe diarrhea was causing large bicarbonate loss. And so just replacing patients' fluid, which they didn't understand volume and amount and things at that time either, was not sufficient in preventing some of these children from dying. But when he added a basic solution, such as a lactate salt, into the ringer solution, less people died. And so, you know, at this point, they were measuring different chloride ions, but the understanding of acid-base interaction physiology was not that well understood. But they did show that, you know, maybe one type of fluid is not perfect for all situations. And so just kind of one thing to keep in mind. So that's kind of where we got a lot of the basic solutions. So just to review what are the composition of the solutions. So I have them up here. Plasma-lyte is essentially made to be quite similar, but not exactly the same as plasma, but just based on salt. So you have a buffering component from the gluconate and acetate, and then you have near physiological equivalents of sodium and chloride. You also have some magnesium and potassium. Lactated ringers uses primarily the lactate salt, which of course, remember, has to be converted into the bicarbonate form through the Cori cycle. So you have to have a functioning liver. Also helps to have functioning kidneys as well. But most important, a functioning liver. Also includes some calcium and potassium. And then saline, which is just 154 milliequivalents. Saline, 154 milliequivalents of chloride. So when we infuse, not just normal saline, when we infuse any type of crystalloid, whether it's a medication, whether it's anything, it affects vascular permeability. And so this is something that we know more of 100% now because we can actually study it, and we'll talk about it in a second. So what I have depicted up here is just a graphical depiction of the endothelial glycocalyx. And so the endothelium layer is here. This polysaccharide protein combined with many different types of molecules is the actual endothelial glycocalyx. And you can only look at this under an electron microscope. So we'll talk about why that's important in a second. But what they've been able to show is that even just infusing crystalloid fluids causes the endothelial glycocalyx to downregulate and be destroyed. And there's some theories as to why that happens, but we know that this doesn't just happen with fluid infusion, it also happens in disease states. But we do know that infusing fluid, and definitely saline, alters this as well. One of the other things to kind of go against the concept of using a high chloride solution like normal saline is that the renal blood flow itself is altered by both the sodium and the chloride. So this, I'll just briefly mention this because we'll talk about a human study next. This was just animal models, whether it was a denervated kidney with a direct renal infusion or a transplanted kidney onto a carotid to allow for more use. They were able to measure the actual blood flow in the kidney when compared for high concentrations of chlorine and high concentrations of sodium. And you can see that the renal blood flow alters in the presence of that. So we know that it regulates renal blood flow. And the chloride itself is specifically associated with reduction in renal blood flow. And when it says normal saline here, or sodium chloride, it's not 9%, it's a more physiological one. So it still has a little bit high chloride, but the sodium level is closer to 140. Okay. So can we show that this happens in humans? And the answer is yes, 100%. We got 12 healthy human volunteers, measured the renal blood flow and their cortical perfusion with functional MRI. They injected 2 liters of saline or 2 liters of plasma-lyte into people and looked at the renal blood flow and MRI. So healthy people, not critically ill people, but this is kind of the best we can have for this as well. But all factors associated with renal blood flow are worsened by saline. So saline is going to be these squares with the dotted lines. So the velocity, measured velocity in the renal blood flow reduces, the renal volume increases, the cortical tissue perfusion decreases, and all of that is associated with increased sodium chloride levels circulating in the blood. So it affects the renal perfusion. So that we know. Is it associated with acute kidney injury? So this is where we're going to start getting into some more disagreements in the literature. And there isn't an incredible amount of abundance, but I think that there is a lot of signal in the literature, but I also agree that a lot of the literature is not very good. So I've only included a few things here, and I'll mention the meta-analysis that does include the rest of the studies. So the risk of acute kidney injury with saline. So this was a very interesting study. It's prospective, it's open label, which was kind of the idea that a lot of different solutions come in a lot of different packaging. They just logistically didn't want to change that. But they did basically a sequential period study in which the entire hospital university health system was using fluids regularly as they used them. This was back in 2008, I think 2009. And then a group of intensivists said, we want to see what happens if we change all of the emergency department and all of the ICU to not allowing normal saline. So they banned normal saline, they banned hypertonic saline, they banned starches, and they banned, because they still use them there. This was in Australia, and any other, and albumin products. So they banned those, and but you could use a buffered saline solution. So you could use a lactated ringers or plasma-lyte or isolate. And you could use those in situations, but you had to ask the intensivist specialist whether it was a neuro ICU or something else if you felt there was an indication otherwise. And only they would be allowed to actually prescribe that type of medication. So they looked at about 6 months of time period and then matched it seasonally the following year after the change and looked at the comparison of kidney injury, which was the very specific primary outcome. Because nobody felt that it was going to change mortality, which is something important that I think I understand, is like the amount of fluid that we use now, because we recognize how volume overload is bad, is probably more important than what fluid type you use. But they wanted to see if it could make a difference. And it actually did show that the proportion of patients was significantly less, who had kidney injury was significantly less. The rates of renal replacement therapy didn't really change that much, but the hospital-free days, ventilator days, and vasopressor use requirements went down. And so this institution still actually does it. So it's only one place, it's only one institution, but just something to think about. Then there was another subsequent trial, a split trial, which looked and compared also for propensity for renal injury and renal replacement therapy, which showed that your buffered saline or your buffered solution, your saline solution didn't really make much of a difference. Key difference though, is that as these studies started going on, we've using less and less and less volume. So the average amount of volume used in that prior study that I mentioned was about 4 to 5 liters. The actual amount of volume used in the split trial was 2 liters. And then the SMART trial, the SMART AD, and the SMART ICU trial, all less than 2 liters, about 1.8 liters from them. So our natural progression of our understanding of fluid management probably has had an incredible impact on mortality as well too. So using less of something that could be toxic probably is going to cause less toxicity. So it's going to be a lot harder for us to actually determine if these studies show it. So I don't like the SMART, and even though they kind of in the papers argue the point that I'm trying to make, I think that they were poorly designed for the study that the question, which is why I'm not actually including them specifically. because I don't think they're asking the right question. So much more of the fluid that they used was actually just from medications, and we have no way to control or use what types of fluids are done from that. So is there a systematic review? So the most recent one is from January of this year. It is a systematic review and meta-analysis done properly through the trials, but it is limited significantly by the fact that all the studies that I told you I think are severely flawed, and huge portions of it are weighted towards the SMART trial and one of the other trials that I mentioned as well too. So they conclude in the paper, and I'll just kind of point out here the overall value of risk reduction. It actually does not, the confidence interval does not cross zero, or it crosses zero. So if you were thinking about it in this single specific term, they would argue no, it doesn't actually denote significance. But when they set up their trial, they set up their trial with a Bayesian approach instead of a finite approach, just saying the cutoff value is 95% confidence interval and whether we make it or not. They determined that through their Bayesian analysis, assuming that you knew nothing about the patient going in, what their fluid status was, that the fluid could make up to about 90% probability of changing someone's outcome or death. Whether you believe me or not, you know, that's okay. I think the studies are pretty terrible as well, but I think there's a lot of signal in the literature that it may not be the best thing out there. We also know that saline has increase in mortality in patients with SIRS and sepsis. I recognize the severe limitation of this. Many people who are diagnosed with SIRS, especially by your EMR and our current SCP-1 guidelines, don't actually meet sepsis criteria, so I recognize that. But people who receive a lot more chloride are associated with a higher mortality. That's been shown over and over again. I think there are a lot of limitations looking at it this way because I recognize sicker patients get more medication, gets more things, so that might be, it might be more of an association. But with a lot of the pathophysiological basis shown in the human and animal studies, it kind of makes sense. So in talking about this one aspect, before I just briefly go on to the next, you know, I don't think that I can stand up here and say, you can't use this fluid because of X, Y, and Z. But I think the reality is that there's a large amount of information out there that shows that we never really designed this drug, medication, properly in the first place. And that there's no evidence that it's superior to anything else. And there might only be evidence that it's harmful in certain situations. So we should probably take a more individualized approach as to who the patient should be receiving fluids from. So we do know that in patients who have severe traumatic brain injury, utilizing more buffered solutions might actually have a signal towards harm, right? Doesn't mean normal saline is the correct choice, but it's certainly a better choice in that scenario. And so that we know. I do know that if you have a severely hypochloremic metabolic alkalosis from severe vomiting, normal saline is totally an appropriate choice as well too. So I think the idea is that, you know, based on what your patient's condition is, maybe there's a better solution. A lot of people are going to say, well, these balanced salt solutions are more expensive. Well, they're only more expensive because we use them less. If we use them 80% of the time, just like we would use normal saline, it's still just a salt solution. It's just chemicals put into a distilled fluid to allow for a safe transfusion. So it's not like it wouldn't be scalable, but just something to think. And then I, of course, concede that there are not very good clinical trials. So the last thing that I really want to focus time on is endothelial glycocalyx. So just briefly, I mentioned what it was, that it's this layer that lines the epithelium. Why are we hearing more about it now, and not really something that we studied, at least I didn't study in medical school, this is a picture on the left of a high-powered microscope looking at endothelium. This is the collagen in the interstitial space pointed out here. This is the alveolar epithelium. This is the alveolar air space. And this is the capillary endothelium. So this is as good as we can look with optical microscopes, best you can see. Problem is the actual endothelial glycocalyx is beyond the scope of optical light looking at it. So it requires a scanning electron microscope to look at it. And it's made up of polysaccharides, primarily not proteins. So we study large amounts about proteins. We study large amounts about things that we can look and see at. But on something that requires rigid, specific preparation and often destruction of the material that you're looking at to look at, it's very hard to study its natural processes and function. And so only really in the past 5 years have we started to develop more technology to actually look at therapies affecting it and to recognize its alteration in many different disease states like sepsis. And so its breakdown probably from the inflammatory cytokines and some of the inflammatory processes going on likely lead to what we see as third spacing, capillary leak, volume distribution. All of this interplays with it. What to do with it, we don't know yet, but we're going to in the next few years. And so just briefly, like it maintains that tight surface, it limits fluid loss and maintains homeostasis of large volume molecules in circulation. It also prevents the inflammatory cascade of clotting. So forms of DIC forming from sepsis probably come from this pathway. The microcirculatory clotting cascade that we see in severe septic shock with like microthrombi, things you would see in COVID, probably come from destruction of this as well too. I'm gonna go through that. So this is just a picture of the damaged glycocalyx that you can see from a scanning electron microscope. And this is a graphical summary of all those different things that I mentioned about how blood homeostasis, clotting cascade homeostasis, the demargination and immune response are all regulated by the endothelial glycocalyx. And we also know that giving people volume, this was actually done with a balanced salt solution, that when you give people volume, one of the proteins, syndecan-1, which is specific to the endothelial glycocalyx that they've been able to figure out, it increases significantly when you load volume to people. If you just change their hemoglobin concentration, which is the normal volemic hemodilution over here, it doesn't change. So infusing large amounts of volume alters the endothelial glycocalyx, likely destructing it. We have to assume that's what's happening because this only increases in turnover, but that's the best that we got. And do other solutions do that? The answer is yes, all other solutions do it. The amount of albumin's effect hasn't been as well studied, but it is being studied a little bit more. It still affects the breakdown of the endothelial glycocalyx, but not as much. But one thing that we do know that doesn't is FFP, right? So why do we think that large volume resuscitation without FFP in patients who are bleeding leads to mortality? Because we're infusing crystalloid solution, which is not a replacement for plasma, and it destroys the rest of it, leading to endothelial capillary leak, tissue edema, inability to perfuse the patient, and then horrible downward spiral of acidosis, poor perfusion, hypothermia, and everything else. And so it's all related. And so that's probably why our more balanced actual transfusions work. So how do we maintain the homeostasis of the endothelial glycocalyx? Avoid volume overload, limit the inflammatory response, so treat the infection, find the infection, and then other further therapies which need to be studied, but I think are currently being studied and will potentially change resuscitation, is that in prolonged resuscitation, so not in patients right up in the ER. Right up in ER, it's probably always going to still be crystalloid, but if your patient's boarding in the ER for a long time, becoming more hemodynamically unstable, a continued resuscitation with something like albumin or FFP might actually be more appropriate. And so albumin has a lot of functions. I'm going to spare some of the details of that. But I do want to talk about the literature behind albumin. So there is no literature that supports albumin's use. I acknowledge that 100%. The more appropriate trial that looked at this, but I still think it was the wrong trial, is the ALBIOS trial. So it didn't actually look at anything about resuscitation. It just said people's albumin should be this level. So they measured the level and then infused concentrated albumin to keep it a level that high. Surprise, nothing really happened. It didn't change renal outcomes. It didn't change anything else because we don't just keep a blood level marker high, right? Like that's not the rationale that you would try to use it. One of the things that you would have to look at is using it as a resuscitative fluid. Is it doing things that we know are associated with reduced mortality? Is it restricting the amount of volume that you're giving? And I would argue probably yes, because it lasts longer, you're going to use less of it, and so on and so forth. And then there was a meta-analysis, but the meta-analysis is of 3 really crappy studies overwhelmingly done by the ALBIOS trial. So they argue in septic shock that albumin might be more effective, but I don't think the data is sufficient enough to say that, but it's something to look into. And so how does fluid overload affect everything? It's a spiral of death, just like with the right ventricle, right? So fluid resuscitation leads to interstitial edema, which leads to visceral swelling, and all of your compartments that are closed, right? Your kidney is encapsulated. You can only swell a certain amount before it actually starts getting ischemic. Your liver is encapsulated. A lot of organs are encapsulated, and there's a limit to the amount of swelling that they can get before they start getting poor perfusion. And then, of course, you can even get intra-abdominal hypertension, thus further limiting to macro hemodynamic compromise. And so you may not notice that you're having organ damage from tissue edema if it's not as severe as I'm talking about with intra-abdominal hypertension, but it's still certainly possible. And then this is kind of a summary of all of the deleterious effects of fluid overload, which we know. And then some of the last things that I want to talk about is how much fluid, right? And so I think I'm probably preaching to the choir to everybody here, but just so you know the history, because I love the history of these things, there's absolutely no basis for 30 milliliters per kg whatsoever in the SAP recommendation guidelines. If you dig back through all of the original trials, including the Manny Rivers trial, so they averaged about that amount of fluid, and then in the subsequent trials, Process, Arise, Promise, and then the Impress longitudinal trial, like it just kind of, just like using normal saline, it kind of just started happening, and it never stopped. But if you actually read the most recent SEPSIS 3 guidelines, you'll realize that when they talk about it, they go, there is zero evidence for the rationale behind this, but we're going to do it anyway. And so it's very hard to undo these things, but we know that hypervolemia can cause problems. So the important part about this is just think about it. Does your patient need so it doesn't even mean that will they respond to the fluid? Do they need the fluid? Do they need the fluid to maintain perfusion? Do they need the fluid to maintain hemodynamic stability, things like that? And that sometimes you may not want to give it. And then we also know that there's a specific dose response with the amount of fluid that you're overloaded with. So this is liters per kg as a percent, meaning the amount of total body additional fluid you received after admission or coming to the hospital, reflected as a percentage of your body weight. And so it's widely accepted that more than 10% is considered grossly fluid overloaded, and more than 5% is considered slightly fluid overloaded. And you can see that your mortality increases linearly as we go from there. The red lines are the 95% confidence interval. And then, of course, this is kind of a play off the vasoplegia talk that I had from before, that your Starling curve is not the same as your patient's Starling curve, which is not the same as your patient's Starling curve in the next 30 minutes. So all of these things change. And it's important to understand that most people with severe sepsis, and well, I shouldn't use that word, most people with septic shock have some level of cardiomyopathy going on as well too. And so just know that, right? So volume is not always the answer. And then I'll end it lastly with the fact that all of our measurements of volume responsiveness are wrong. And I really like ultrasound, and I use ultrasound for everything and look at it, but there's not a single patient that we're going to take care of that really meets this criteria. If you're working in a surgical unit, you might meet this patient criteria a little bit more, but if you're resuscitating a medical resuscitation or a patient with severe septic shock and things like that, ARDS, your patient doesn't meet any of these criteria, and it's almost impossible to get them to meet the criteria. So we look at it, but I just want, and I look at it still too, but I want you to recognize that it's not much different than CVP, right? And we don't use CVP to guide our fluid maintenance or anything anymore. And so in the extremes, it may be helpful, but also in the extremes, it can be wrong, right? You're gonna have patients with high pulmonary vascular resistance with ARDS are gonna have high right-sided pressures. Doesn't mean they're volume overloaded, doesn't mean they're underfilled. You don't know, and sometimes you don't know without trying. So this is kind of a summary of some of the false positives and false negatives and situations in which we're going to take care of these patients. So a surgical one, open chest, obviously the pressures are different. Increased intra-abdominal pressure. So patients who are already fluid overloaded, your reliability of this might give you a false positive. Very high respiratory rate almost always gives you a false negative. Right heart failure, which we are starting to recognize more of its importance. In that situation, you can't use the right-sided pressures because they're wrong. And you don't know if they're wrong because of volume or if they're wrong because of the function of the right heart. And spontaneous breathing, which is a lot of our patients when they come into the to the ICU, right? And then there's some decision curves that people take, right? Is hypovolemia obvious? Okay, sure, give them fluid, right? They're bleeding out on the floor, or you saw that they dumped like 3 liters of urine, you know, there might be something going on there. But take into account, and this is something that Ray always mentioned as well too, take into account what it was that triggered your reason to give the fluid and reassess that thing, all right? Was it the patient's heart rate? Was it's the patient's blood pressure response? Was it their capillary refill? Was it some other type of evaluation that you used and you feel reliably that this is becoming a marker of what's going on, and use more than one, right? Use ultrasound, use history, and examine physical. And the last thing that I'll mention is just that, you know, I develop a pre-test probability of what the patient needs, whether the patient needs fluids before I do any type of test, right? So from the history, from the physical, from the amount of fluid that the patient's received, have they been vomiting for 3 days and feel ill? Are they febrile? Like, what is the likelihood that they're going to be volume depleted? And then if I'm not sure, then I'll do a test and look and check. So the power of my tests are going to be more effective when my pretest probability is higher. And then lastly, what are the only things that I think probably make a difference that we're not going to really do in the emergency department? We rarely even do in the ICU. Measuring continuous cardiac output with a passive straight leg raise or a bolus of fluid and showing that the cardiac output increases, that's good. Are we going to really do that? Probably not. It's logistically impossible to do. Oftentimes people do it wrong. And we don't have a way to reliably get continuous cardiac output. Even echo can be unreliable in this situation. And then the other test that you can do, and I wanted to include it just in case people haven't seen it, is the END-EXPIRATORY occlusion test. So in patients who are being ventilated, you're going to do an expiratory hold. You hold it for 15 seconds, and you have to also continuously monitor their cardiac output. Does it increase more than 5% after those 15 seconds? And then when you let go, do they return back to their baseline? If so, they probably will benefit from fluid. But all of these would require either a swallowing catheter or someone who is standing there at the bedside, helping, looking, keeping the same exact position of the echo and measuring it in sequential orders over time. So our technology to measure this stuff is not quite there yet, non-invasively. And we aren't going to invasively monitor every single patient, right? So just something to keep in mind. And that's it. I know I went over a little bit of time, I apologize. But thank you for listening to me harp on about fluids. And just know that fluids are a drug. Our approach towards restricting the amount of volume that we're giving is probably the best we have for now, because there's no appropriate, safe intravenous fluid medication that we're giving people. That's all I'm going to say.